for inviting me, and I hope everybody who is logged in can hear me. I've been in the UK and have had looked after a lot of babies who have developed, unfortunately, NEC. So it's always challenging to see the babies suffer NEC, and it's always interesting to know what more we can do to prevent or decrease the risk of NEC. So I was asked to look at what are the recent evidences. So I thought briefly in the next kind of 25 minutes, go through the recent literature. I focused on the last 5 years PubMed search because of the current era of meta-analysis and reviews. I picked up the articles which are more kind of a review and then summarize, if I can, in the next 20 minutes. So we do know that NEC is a disease of the extreme preterm and preterm babies. I would like to start with a story of a preterm baby, which is always fascinating for neonatologists. Theo, who is in the public domain, he was 330 grams when his mother came to me in the UK, and there was discussions about what do we do. We did give a very less survival rate, and of course they went on to deliver. He was 330 grams and went through the process of usual extreme prematurity, including NEC, and luckily he didn't develop surgical NEC. If anybody's wondering why he's carrying a Coke can in this picture, it's simply to give a layperson a comparison. He was as heavy as a Coke can when he was born, and is well and thriving now. So with that background story, we all know when we have a extreme preterm baby born in the unit, one of the nightmares is, oh God, you know what is the chance of him getting a NEC? And we do know NEC kills more deaths than all childhood leukemias. And just briefly talking about the background incidence, we do know the NEC incidence are 5 to 10%. The more smaller the gestation, more early the gestation, more is the incidence, and more surgical NEC, thus grey shadows. The more smaller the baby, the more is the chance of the NEC. Again, more surgical NEC in babies who are below 1 kilogram. So, of course, it is a huge issue for extreme preterm babies. I would like to bring this again before we go on further detail about the outcome, because we do know NEC is a killer, but equally in those surviving, NEC causes significant morbidity. Specifically in terms of the brain, I would like to talk about. So this is a study way back in 2004. They looked at various domains of neurological brain outcomes, especially the developmental index, and compared the babies with NEC and sepsis with those who are completely clean. And as you can see, an episode of NEC with sepsis almost doubles the incidence of poor developmental outcome. It's almost like a dose-dependent lesion. So 22% to 42%. If you go on to any of these domains, they're all almost tripled or doubled if the baby has sepsis in NEC. So that's huge implication in the current world of IQ and high-skilled skills which are needed for the future. So what is known for us is NEC is a disease of preterm or prematurity. The question is, can we prevent prematurity? Of course, it's a question. Of course, we can if we can, but there's no specific magic bullet. But the most of the intervention should be at the public health promotion, because we know some of the maternal morbidity increases the risk of prematurity, specifically like maternal smoking or high BMI in the Western world, and the general maternal health in principle. Therefore, the programs to look at the promotion of maternal health is hugely important. There was a study which looked at specifically intervention study to look at decreasing the chances of prematurity in preterm delivery and the outcomes. The outcome trial. Unfortunately, there was no significant results by giving a prophylactic progesterone to women. So what we're left with is the interventions which we need to do as neonatologists straight from taking from a delivery, including practices like delayed cord clamping. So obviously, there are a lot of intervention, including as many as 110 interventions has been looked into. So we will focus on some of these key areas which we know before, and then a few of them which perhaps has come up into light in the last few years. One thing again and again I would like to make emphasize is the breast milk is the milk for the babies. So please think about breast milk when the babies are born. And in fact, in many units we practice discussing with the parents antenatally, and there are some women who express the milk antenatally in store. And I've had this women in Western world, and of course we can do it here too. So I just want to bring your attention to a recent review article which talks about an overview of systematic reviews of RCTs for preventing NEC in preterm infants in last year in neonatology. So it basically gives an insight into the interventions which have been done so far, which are in practice and which does help decreasing the risk of NEC as a theory of a marginal gain. So there's no single intervention, but a group of interventions. So this table shows the various interventions. The left side here, the various studies and number of studies included in this review, and the intervention to prevent NEC is what they're looking at. And they're looking at the certainty of evidence now. It's not just the evidence, how certain we are that this study, full study, is giving an indication that this intervention decreases the risk of NEC. So the good old things like antenatal steroids, thank goodness we have that. That's clearly shown the benefit of decreasing the risk of NEC. I'm not going to talk about probiotics. We know over and above it helps, and the treatment for PDA. So one caution of note here is the use of many of these interventions, specifically like probiotics, depends on the type, the amount, and what type of probiotics using. And these things are only effective in the unit where the background risk of NEC is high. So if you are using probiotics in a unit where the background risk of NEC is like almost negligent, like in American hospital, we have very less incidence of NEC, then it may not be helpful, or it may not show the benefits of what it does to decrease the risk of NEC. So moving on, the intervention which perhaps helps in preventing surgical NEC. There are many, most of them are around the breast milk. So the breast milk is the key to prevent or decrease the risk of surgical NEC, including some studies on oral immunoglobulins, because we do know the breast milk has many immunoglobulins, which perhaps helps the gut health. One thing to note here, I'm sure we all moved on away from lowered oxygen saturation targeting. Lower oxygen saturation targeting is associated with the increased risk of NEC. Therefore, we do know that these interventions as a collective effort does help decrease the incidence. So we all know these things are in practice and we all are doing it, but still NEC is a big killer in many parts of the world. So there's no magic bullet, but a kind of a theory of marginal gain where every little helps. So we have to do everything which we can as a team approach, as a collective measure to decrease the risk of NEC. So I was looking at the last 5 years. What are the new interventions? Those of them could be older. I'm specifically looking at the literature review and systematic reviews and meta-analysis. So I come across oral colostrum. So I started using oral colostrum way back in 2013 when I was a consultant in Newcastle, where Dr. Embleton has done a lot of studies on gut microbiome, and we were practicing giving oral colostrum through the cotton bud, basically smearing to the buccal mucosa, very small amount as soon as it is given by the parents, usually in the day 1 or day 2. We often used it for when we do a procedure on the baby, just as a calming effect. So there was a recent review of the many RCTs, which was reviewed by Ma et al., which came up in the article in 2021 as very recently. So they looked at all the studies, including randomized controlled trials, as well as some of the core studies, and see the benefit of oral colostrum, meaning oropharyngeal colostrum. Does it have any implication to decrease the risk of NEC? So they were basically looking at effect of colostrum when ventilated pneumonia, but within that there was also a section on NEC. However, they also did a separate review of oropharyngeal colostrum and NEC, but that article was pretty much like similar to this one, therefore I did not include that. So if you look at this forest plot, these are the studies we have. The total number of babies here, 300 or 600 babies together. These are the babies who had oral colostrum in the first few days of their life. The description given is 0.2 mL with a cotton bud split across both the mucosa of the inner part of the cheek. So not supplementing, not giving as oral, but smearing into the oral mucosa. And these are the control groups, and these are the total number of babies. Clearly, the incidence of NEC trended more, decreased in the group who had oropharyngeal colostrum compared to those who did not have it. And the risk reduction is around 3% difference between these two groups, which is hugely important. Though the conclusion of the study was that there's larger RCTs are still needed. But the key thing is, oropharyngeal colostrum does not cause any harm. It does promote other things like establishing the feeding early. I hope you can see the slide on the last slide, because I can't see it here. The time of full enteral feeding in the babies who received oropharyngeal colostrum was much earlier compared to those who did not receive it. They were enhancing the hospital stay, decreasing the hospital stay, and promoting early discharge. One thing to note here also is the effect of oropharyngeal colostrum on the chest infection. So all this has got a huge impact on the baby's health. So in principle, I think we have to promote use of colostrum in the early days when babies are still ventilated and not to be fed. Moving on, the other big thing which has come up recently is the lactoferrin, which is a whey protein, the second largest whey protein in the breast milk. Lactoferrin as a molecule has got a various physiological role, including immunomodulation, gut promotion, and it promotes the growth of the healthy bacteria. So there are a lot of studies looking at lactoferrin, including the elephant study, which was done in UK, which was part of. There was a review done by this group, which came up, I think, in this year, which looked at various studies of lactoferrin given to women, given to babies who are either less than 32 weeks or very low birth weight. So this is the elephant study, which looked at giving bovine lactoferrin to babies in the first 3 days and randomized control who received sucrose. This is the largest study so far, with close to 1,500 babies. There was also, close to 2,000 babies. And also the LIFT trial, which is from New Zealand, Australia, which pretty much similar to elephant study in the UK, supplemented the babies with bovine lactoferrin. There was an interesting study by Okova. This study is basically a subgroup. It's a part of the larger trial. I think it's called NEOLAC trial, wherein they looked at women who were not given a bovine lactoferrin, but those group of babies who developed NEC. They then analyzed the women's breast milk who had how much lactoferrin and what their relation to the NEC. And they clearly showed in the paper, which was published, that the women with a relatively larger amount of lactoferrin, their babies had relatively less incidence of NEC. But this is also included in the study as a meta-analysis. The other study is a Sherman 2016. This was again a human-based recombinant lactoferrin, which was studied in this study. But so basically, these two are human lactoferrin, but the rest of all bovine lactoferrin. So in principle, there was no significant effect of lactoferrin on the decreasing the gut injury, but there was a lot of trends towards decreasing the risk. However, when you combine the lactoferrin with probiotics, the reduction in the gut injury is significant. but we do know probiotics in itself can have an effect. Therefore, I'm not going to dwell more on that. So in principle, lactoferrin has got a lot of scope and more evidence is needed. Moving on from lactoferrin and colostrum, we do know the good old practice of standardized feeding regimen is very important. There are a lot of reviews on it, and we do know with the diversity of practice, sometimes we often let loose this practice. So there was recent evidence from 2017, a standardized feeding regimen for reducing NEC and preterm infants. They reviewed various studies, including cohort studies and randomized trials. I don't want to dwell too much on this, like 1,000 babies, almost 20,000 babies in the two arms. Standardizing feeding regimens significantly decrease the risk of NEC. This is something we have to often promote. Of course, we have to tailor the need of the feeding based on the need of the baby, but in principle, we have to practice the same so that the incidence of NEC doesn't come down. Moving on from that background, then there's a question about how soon or how fast we should increase the volume of the milk. What I mean is it 10 ml per kilo per day after initiating the feed, or is it 20, or is it 30, or is it 40 ml per kilo? So what is the right speed of increase? To be honest, nobody knows, but what we know from the literature review, which includes various speed of increasing trials, which was recently done by Samodi from Bradford, published in 2017, which includes our own UK study SIFT trial. In principle, if you're increasing your feed slower, the SIFT did 18 ml per kilo to 30 ml per kilo. The other trials which looked at 24 ml per kilo, 15 ml per kilo, but in principle, below 20 ml per kilo does not decrease the risk of NEC. However, it does increase the length of stay. So therefore, there is no reason to believe that the slower speed of increase decrease the risk of NEC. However, the faster group, though there was no increased risk of NEC or decreased risk of NEC, it does promote early full feeds, thereby perhaps early lines out and thereby possible late onset infection. So the speed of increase in feeds, in principle, slow feed does not help in decreasing the risk of NEC. Therefore, in principle, we should not be doing it. So moving on from the speed of increase, there is an entity of TANIC, the transfusion associated NEC. So the various case reports and a few randomized trials which looks at is there a relation between blood transfusion extreme preterm babies and the risk of NEC. TANIC is usually defined as NEC in the first 2 days of, NEC following within 48 hours of transfusion of blood. So in this study in 2017, they looked at the quality of evidence for the studies which has been done. What is the quality of evidence, and does it have any implication to decreasing the risk of NEC? There were around 23 observational studies, 3 RCTs. I really mainly focus on the RCTs because observational studies can be quite biased. So the numbers are very minimal, like 200 in each arm. And in principle, I don't want to dwell on the individual details of the study. If the babies who received less transfusions had more risk of developing NEC compared to those who received more transfusions. So the threshold for transfusion had an implication for instance of NEC. There are many reasons for it. In principle, it could be because of holding on to the low hemoglobin for a longer time, leading to gut hyperperfusion, hypoxia, the dynamics in which the cardiac output, these things may have influenced the gut perfusion. There was also, further to this, trials looking at should we be holding the feeds during blood transfusion, and does it make any difference to the NEC? There are some physiological studies to suggest which are shown by withholding or giving the feeds during blood transfusion, there is no difference in oxygen, oxygen saturation or blood flow to the splanchnic circulation. Therefore, in principle, transfusion associated NEC is an entity which is still questionable. At the moment, there is no indication that it increases the risk. In fact, people say it does increase the risk if you don't give transfusion. However, there are some case reports to suggest there are some large audits to suggest that the TANIC is more often seen in babies below 26 weeks in the first 2 weeks when they get transfusion. but of course the jury is not out. Moving on to the TANEC, again, people looked at again a systematic study to review other various control studies and case control studies, cost studies to analyze is there a risk of NEC in the babies who develop NEC following a blood transfusion within 2 days of transfusion. And overwhelmingly, if you give less transfusion in that unit, there was increased risk of NEC. So in principle, TANEC is at the moment questionable, and withholding the feeds during blood transfusions again questionable. There are trials going on looking at withholding and giving feeds whilst we give transfusion. So moving on to the other molecules, one of the key things just come up recently is the human milk oligosaccharide. So oligosaccharides are present in abundance in breast milk, especially in the first kind of a few days. This is an interesting article which came up in 2017 looking at human milk oligosaccharide composition.
Dr. Ramaiah, you have 2 minutes more.
Thank you. Does it predict the, sorry, I started at 10 past 2. Is it okay to take 5 minutes, please? Okay.
Yeah, what do you say, Rick? Can you repeat?
I started the meeting at 10 past 2. Can I take 5 minutes, please?
Oh.
Thank you.
It's okay. It's okay. Go ahead. Yeah.
Thanks so much. So the sorry for this interruption. So the human milk oligosaccharide composition predicts the risk of NEC in preterm infants. So they beautifully narrated this. They looked at women as breast milk in the first few days, and then measured the concentration of oligosaccharides, and then predicted the risk of NEC. This chart here shows the time postpartum days and concentration of oligosaccharide, and this is the incidence of NEC. The red dots are the surgical NEC. This is stage 2 NEC, and this is the white circles here are well stage 1. So obviously it's very clear, irrespective of the concentration of oligosaccharide, there's no difference in the NEC incidence in babies. The next thing they did was specifically looking at a component of oligosaccharide, which is called DSLNT, and their concentration, and then in relation to the NEC. It is very clear to anyone that if the concentration is below 200 micrograms per ml, the incidence of stage 1, stage 2 NEC, and includes stage 3 NEC significantly increases. So the conclusion of the study was measuring this specific component might become a predictor of a risk of developing a NEC in babies. And also in the future, it might give ideas about supplementing this component orally, perhaps to reduce the risk of NEC. There are a few other trials which have looked at what are the components of oligosaccharides and how diverse the oligosaccharide and its relation to the NEC. In principle, the more diverse the oligosaccharides, the breast milk, the more chance of the baby having, or less chance of not having a NEC, less chance of having a NEC, sorry, and therefore the less diverse the oligosaccharide, the chance of having the baby NEC is less likely. So there are more trials going on, and there are a few randomized trials, but in principle, oligosaccharide is coming up hugely, and hopefully it gives more future to us in terms of NEC prevention. So moving on, as we have less time, there are many nutritional interventions, which includes various things, which I don't want to dwell too much on. The key thing here are a couple of future trials which will be looking at L-arginine. There are a few randomized trials looking at supplementing L-arginine, which is we know it's a precursor, which is an important amino acid for nitric oxide, and that's which enhances blood circulation. Thereby, there is showing some promising results for decreasing the NEC. Similarly, zinc, there are 1 or 2 trials on it, but still we need a large number of randomized trials to look into that. Similarly, we have glutamine, which again increases the nucleotides in the gut level and shown to have decreased the risk of infection, but no huge effect on the NEC. So there are various other components which have been looked into, which might decrease the risk of NEC, including oral immunoglobulins, which I talked about. There was a study one study about erythropoietin, but there's no concrete evidence that it decreases the NEC. The randomized trial, very less number of babies. The study from, I think, Israel, which looked at lactulose supplementation, and they showed this decreased trend in NEC. And of course, selenium, oral or parenteral, is being looked into. Two things before I end is I want to talk about the twin piglet cohorting study. A recent tweet came to me about the Piglets twin piglet cohorting study, wherein if you cohort the twin piglets together compared to separating them, the chance of NEC is less likely in babies who are cohorted and taken care in a single cohort compared to being separated. So something to look for in the future, how we manage the twins. To summarize the take-home message, breast milk is the best milk. I don't want to overemphasize that. Oral colostrum, I think we should think about using the oral colostrum for the buccal mucosa, as it's shown promising results about promotion of the health, as well as there is no harmful effects so far reported. Other important thing we should do is standardizing feeding regimens so that we all do the same thing in the unit. And we do know there's no point in doing slow feeding regimen because there's no difference in NEC. It does not decrease, but in fact, it increases the length of stay. TANEC, we're not sure it really exists, and oligosaccharides might be a promising future in predicting the risk of NEC. Thank you. I'm sorry if I've taken a bit more time.